nešto su oni isto malo pre to. Okay, thank you. Dear colleagues, ladies and gentlemen, and distinguished guests, I'll try in the next few minutes to present for the beginning one complex case of postdiscecant thoracoabdominal aneurysm. This is extremely, this is a 33 years old male patient who was admitted with a strong chest pain with interscapular propagation and the previously diagnosed Marfan syndrome. In 2015, he was treated in other hospital in the emergency setting because of acute type A aortic dissection. In this time, the Bentel procedure without elephant trunk was done to him. Systemic evaluation in our hospital showed hypertension, moderate reduction of global systolic heart function with the ejection fraction of left ventricle between 30 and 40%. MSCT angiography was performed, and we saw the dissection who was with intimal flap position in the aortic arch between the brachiocephalic trunk and the left common carotid artery. You can see here the 3D reconstruction of whole aorta, and in next few slides I will show you the cross-section multiplanar cuts of this aorta. You can see here the previous rest of Bentel procedure, and on this cross-section we can see the affection of the left common carotid artery and left subclavian artery. The maximal diameter of aorta is 5.4 centimeters at the beginning of descent aorta, immediately after origin of left subclavian artery. The phrenic level diameter is 43 millimeters. The visceral segment diameter is about 4 centimeters, and the pararenal level is 38 millimeters. As you see here, the dissection is propagated at the left iliac artery. What you will do with this patient? Professor Jakob is the first. Where is the microphone? I'm sorry. Yeah.
Yeah, that's the patients we have to deal relatively often. So, starting out with type A aortic dissection, we are very radical. I will demonstrate it in my talk, because they come back. If you just do an ascending replacement, the arch is coming, and then you have another 2 operations coming forward for the patient. So we are aggressive first stage. So Marfan patients sometimes have also mitral valve insufficiency, so we treat that. And if we have time, we do a David operation with reconstruction of the aortic valve, but in most of the cases, if we have severe AI, we do mechanical valve replacement, the total arch, and the frozen elephant trunk in the true lumen down to mid-thoracic level. And then we watch the patient closely thereafter, and if we have growth of the thoracoabdominal aorta, we do the second stage. So we spare the patient one operation. The radical first one down to the mid-thoracic level, and then total thoracoabdominal replacement.
That's great, but we often are not in such a situation. Often they do only the Bentel procedure or the ascending aorta. What would you do in such a case if you had such a case?
Of course, I have to deal with those patients. Then I have to go in there. I have a video part also in my second presentation, where we have to do the arch and the elephant trunk, the frozen elephant trunk, but the patient is facing a third operation.
Yes.
Thank you very much. Any other opinion?
I have a question for Professor Jacob and Chiesa. Would you do operation in this patient in a 5.4 centimeter aneurysm, because patient is young, he is probably connective tissue disorder patient, but the diameter is 5.4.
Had the experience with Marfan's rupturing with 3.5 centimeters, so I don't stick to the guidelines. So, of course, we follow those patients very closely. So we have CT scan every 6 months or so, and if there's growth, we go forward doing the operation.
Thank you. I am the Samiji. It's a Marfan, so I need the operation. The problem is the site of the clampage. Can I have the first slide with
The 3D
yes.
reconstruction. Yeah.
In my idea, if it's possible, I do a clamp between the left carotid and left subclavian, and to replace completely surgery with open surgery, thoracic aorta, and I stop to the diaphragm. I replace completely the thoracic aorta. First operation, and I look in the time for the part of the aorta down the diaphragm. So 33 years, and Marfan, I think that he requires, this is the dissecting aneurysm of thoracic aorta, typical, with reimplantation if he needs of the left subclavian artery. But sometimes it's possible to include the subclavian also in anastomosis. If I cannot, I reimplant the subclavian artery.
But
Why don't do the clamp here?
But what would you do with the dissection which starts at the level of which one you said, Ivan?
Between the brachiocephalic trunk
And it goes to
and
the left carotid
yes,
artery,
both.
the dissection.
But exists a dissection of the left carotid artery or not? Yeah.
Yes.
Yes,
Yes.
it is affected.
Well, it's possible also to wait. It's possible to see. Possible. You think that you do Evita in these cases?
Yeah, the arch has to go, sorry.
Okay.
Yes.
Okay. Thank you. Any other questions or opinions? Thank you very much. Sorry?
We have the second case.
Yeah.
If we have
We'll
time
go
for
to the
this session.
second case. Of course, we have time.
The second case is very interesting. This is also a very young male patient with Marfan syndrome. Initially, he was admitted in 2050 because of ultrasound diagnosed the small abdominal aortic aneurysm with a maximal diameter of 45 millimeters. When we performed him the MSCT, we saw that he had a chronic uncomplicated aortic dissection with the origin in aortic arch. Brachiocephalic trunk, right subclavian, left common carotid artery, left vertebral artery as a separate origin, as well as the left subclavian artery were affected with the dissection. In that time, systemic evaluation showed hypertension, obesity. This is very, very obese young patient, and mitral valve prolapse with ventricular extrasystolic arrhythmias. Due to absence of symptoms, diameters, and comorbidity, at that moment, patient wasn't considered for surgical, hybrid, or open repair. 3 years later, we performed the control examination, and we saw the all diameters progression. For example, you can see the pararenal segment was 77 millimeters, and additionally, we performed the transesophageal ultrasound and saw the aortic bulb aneurysm of 58 millimeters. We consider these patients for multidisciplinary approach, and what is your experience and what you will do?
So, yeah, okay.
In my opinion, first the treatment, the ascending of the arch with the technique of Professor Jakob. After this, repair of all descending thoracoabdominal aorta. 2 times, first ascending and arch, after thoracoabdominal.
Yeah, I fully agree.
Thank you
I
very much.
can say what we consider. We made a consultation of cardiac surgeon and they performed him the Bentel procedure again without, I can underline, without elephant trunk last year. And after that, you will do what? If you have a similar situation.
Watching the patient closely, what's going on in the arch and the thoracoabdominal aorta. But this is, I would expect him to come back twice. So with the more aggressive primary approach, you save 1 operation for those patients.
But the patient is in a problem. He has 7 centimeters aneurysm in the
And
level
the
of renal
parallel
arteries.
segment,
So it's kind of similar like the first case. Then they have done the Bentel operation without elephant trunk. You have the arch. You have the descending aorta again.
One of the most important messages regarding the both previous cases that during the primary procedure, cardiac surgeons should be much more aggressive.
Yes.
Any comment?
What did you do there?
We performed the TIVAR with the proximal debranching in zone 1.
Zone 1.
Yes.
If we have no comments, I would like to thank you all for this first session and ask you to have a coffee break in endurance of half an hour, and then we will proceed. Thank you.